Good afternoon, everybody. It is July 1st. It is about 2:10 p.m. or 2:10 p.m. Eastern Time here in New Jersey, and we are live with Dr. Maron of Tufts in Boston, where it is also 2:10-ish. And we are going to have a discussion today about an article that was recently published, which I have right here in front of me, and you can get on the HCMA website. It's entitled Enhanced American College of Cardiology and American Heart Association Strategy for Prevention of Sudden Death in High-Risk Patients with Hypertrophic Cardiomyopathy. And we are going to get into some really interesting conversations with Dr. Martin Maron. So welcome, Dr. Maron, to the HCMA Facebook page.
Thank you, Lisa. Always good to be here. Hello, everyone.
Okay, so as people are populating in, so let's just spend a little bit of time with a little history about the enhancement. So where did the first documentation of sudden cardiac arrest risk assessment come from AHA and ACC, and why is this an update?
Well, the first formal recommendations about how to risk stratify, or recommendations for risk stratification for HCM, were in the 2003 ACC guidelines, and then they were updated in 2011 in those guidelines, which were ACC AHA guidelines. And now what we've presented in this article is something we've termed enhanced risk stratification, which means that we have incorporated, since the 2011 guidelines, additional strategies and markers that we believe, as we've shown, enhance or make more reliable the risk stratification strategy that was promoted back almost 10 years ago at this point.
So let's take a look at some numbers, and then we'll kind of break it down for everybody. So we started here with almost 2,100 HCM patients, right?
Correct.
And this is all out of one institution?
One institution, Tufts in Boston, yep.
Okay. And how many of these patients actually had ICDs?
I believe it was about 30%.
Okay, so we're dealing with about 527 patients, right?
Somewhere in that ballpark, right.
And of those who were implanted, what was the profile? Do they have 1, 2, 3 risk factors, or how many did they need to be in this study?
Well, what they needed was at least one of what we call a major risk marker.
Okay.
So one major risk marker within the patient's clinical profile at the time they were being assessed as a patient at the Tufts HCM Center was enough for them to be considered at increased risk enough that we made a recommendation that they consider ICD for primary prevention of sudden death.
Okay, so we used to talk about 5 risk factors, but this document talks about 7 risk factors, and one of the old risk factors is gone now. So let's talk about what these risk factors are now after you've looked at all of these patients with all of these characteristics, and we know that the devices are firing appropriately about, 15% of the time in this population?
Right.
Yeah.
Right.
So what did we learn? Who's at risk?
Well, so I think what we've learned is that we're able to capture, in a sense, more patients that are at risk for sudden death using this expanded or enhanced strategy that now includes, first off, several new markers of risk that were not really part of the 2011 guidelines, because the data supporting them really has emerged over the last decade, essentially. And those include really 3 important issues. One is the patients with HCM who develop an apical aneurysm, thinning of the apex, which is usually a scarred area, the tip of the heart, which we have now recognized as a very high risk type of HCM. That's a new marker.
I'm sorry, the FedEx man just dropped off. Keep going, Marty. I'm sorry.
2 is the presence using MRI of being able to identify a patient with a lot of scarring in the heart muscle. And 3 is if patients with HCM develop decrease in their pump function, what we call the squeeze of the heart or ejection fraction, if that falls, as it does in about 3% of patients, below a certain level, ejection fraction really of 50% or less, that's also indicative of an increased risk. So those three markers really have become more mature. And now I think we, based on this data, are able to identify more patients who are at risk for sudden death by incorporating those three additional markers into the risk stratification strategy.
So what dropped off of being a high risk marker?
Well, what's dropped off that was present in 2011 and before was what we called an abnormal blood pressure response to exercise. So that's when a patient with HCM exercised, typically on the treadmill, and their blood pressure either did not rise enough or actually decreased. Had been suggested in the past that that was a marker of increased risk, and that's why it had been a risk marker before. The normal blood pressure response to exercise is that it goes up quite a bit with exercise, and so this was a abnormal response. And I think the message there is really that probably two things. One is that I think the evidence behind that has always been pretty weak as a risk marker. If you compare abnormal blood pressure response to the other markers, it was always by far and away the weakest predictor. And two is that it was always hard to interpret the abnormal blood pressure response in some patients with HCM, particularly those who had high gradients at rest or who developed high gradients with exercise. The significance of that finding also was always suspect. So for those two reasons, I think there's been a general consensus among the experts that we don't routinely look at abnormal blood pressure response anymore for that reason.
So I'm going to go back and review what the 7 are, and I'm going to ask you to comment on them as we go through. So number 1, family history. But of what? Just HCM?
Well, it's a family history, and there have been different ways of characterizing that definition in the literature. The way that we did it in this paper was, and the way we practice at Tufts, which is a reflection of this paper, is when there's a family history in a first degree or close relative of the patient who's died at a relatively young age. Usually we consider that to be 50 years or less, and that death is judged to be related or due to HCM, with the best amount of information that you can obtain about that cause of death.
Okay. Left ventricular hypertrophy, meaning massive hypertrophy of 3.0 or greater.
Right.
But how are we measuring that 3.0 today? Are we sticking with echo or are we going to MRI?
Well, what we've said is that it's either.
Okay.
So that if you've got a wall thickness of 30 millimeters, measured in your view or the physician's view as being reliable as can be with echo, that can be enough to constitute massive hypertrophy. There's some instances where you get a wall thickness of less than 30 by echo, but it's 30 or more with MRI because of the greater spatial resolution. You can have that kind of situation with MRI where you actually see massive hypertrophy, where you had wall thicknesses that were less with echo. So if you've got 30 with MRI, that also constitutes a risk marker of massive hypertrophy too.
Does this number hold up in the pediatric population as well?
Well, in the pediatric population, there's been different ways of handling this. And what we're talking about is in young patients who are obviously smaller than adults, we're trying to take into account the issue of body size with respect to wall thickness. The pediatric cardiologists have used ways to do that where they have what's called a Z-score, where they can essentially account for body size statistically using what's called a Z-score. And typically a Z-score of 5 or greater in a child or a young HCM patient is something that they've viewed as equivalent to 30 or more in an adult.
Okay. Unexplained syncope as a risk factor. How is that defined?
Well, that's syncope, which is abrupt and acute loss of consciousness. And there can be many different reasons that a patient with HCM could abruptly lose consciousness besides or in addition to an arrhythmic cause. And we view, syncope then to really have the greatest weight as a marker for future risk of sudden death and therefore ICD when that syncope is judged by the history to be most consistent with an arrhythmic etiology rather than a non-arrhythmic etiology or other causes that are common that would include things like neurocardiogenic or vasovagal or due to drugs. Those are really less, what we consider giving much less weight to syncope as being a risk factor. So that's really where the clinician, right, and the cardiologist is important because you really have to be able to, distinguish between a history that's most consistent with an arrhythmic cause versus a non-arrhythmic cause of syncope.
Most commonly, this is an area where people will call and be confused because they may have passed out, but they're obstructed. And if they're not being seen by a high volume center, the first thing somebody wants to do because they passed out is put the ICD in and ask questions later. So somebody who's obstructed should kind of maybe slow the jets a little bit and meet with an HCM specialist before they commit themselves to a device strictly on a faint with obstruction. Yes or no?
Well, I think it's a complicated and challenging area, syncope in the setting of obstructive HCM. Mm-hmm. Because what we're saying, just so everybody's clear, is sometimes with obstruction, particularly if a patient perhaps is dehydrated or what we call hypovolemic, then the obstruction with not a lot of fluid in the heart, so the tank low, can precipitate a loss of consciousness episode for that reason rather than being due to an arrhythmia. So I think, that this scenario of loss of consciousness in a patient with HCM who has obstruction really should be looked at very thoughtfully and carefully by an HCM expert at a center of excellence to really be sure that enough weight is being given to, could this be due to obstruction or is this actually a arrhythmic cause? Okay, because the treatments would be dramatically different in those two scenarios.
Okay, now the next complicated one, NSVT, so non-sustained ventricular tachycardia. First, I'm going to ask you to define that for the viewers. And then what kind of NSVT is worrisome in HCM?
So NSVT is non-sustained ventricular tachycardia. This is the abnormal rhythm that's generated from the bottom chamber of the heart where the muscle is thick. And if it starts, meaning ventricular tachycardia starts and doesn't stop, then that's a concern because that can make a patient pass out. And then if it doesn't stop at that point or a patient doesn't get a defibrillating therapy, that can be a life-threatening situation. So what we know now from several large studies over the years is that if you put a monitor on and you see in a patient with HCM evidence of short episodes of ventricular tachycardia, what we call NSVT, that can be a marker for future risk of a longer, potentially life-threatening ventricular tachycardia episode. The question then is how much NSVT is enough to see on a monitor to constitute a risk that's increased where you would be recommended at that point to have an ICD. And I think we generally do not consider isolated, relatively short and slow bursts or runs of NSVT on monitor to be enough in an individual patient to recommend device. Often should take more burden than that to ultimately consider a patient high risk enough. That can be a burden where the frequency is concerning, or maybe even one particular run is very fast or long, also. So in other words, we put greater weight when we're looking at the monitor on the number of runs, the speed of the runs, and the frequency of the runs.
So there's a slight change from the guidelines here in terms of heart rate. So I believe the old guideline said 120 or greater, and now we're breaking it down to 130 or greater in rate. Am I making that right, or am I remembering wrong?
There was always a little bit of back and forth about the actual just definition of NSVT. Did it require ventricular beats at 120 beats per minute or 130? And there was always a little bit of back and forth about that, but that's not so relevant, to be honest.
But it's more how frequent they are and how long they are and how fast they are. So you have to look at all of the variables together. So to just say I had 3 runs of NSVT, you're missing factors about that NSVT that would help you make the decision, device or not device.
Correct.
So,
that's right.
So rate, repetitiveness, and speed are the key factors.
They are, we would consider that weight should be given to those. Strong weight should be given to those. In addition to, of course, in any individual patient, whether they have other risk markers as well.
Correct. So we've discussed a little bit about LGE, so scarring and MRI, which you've done a little bit of work on in your career. And then end stage, defined as people like the old Lisa's heart, where the EF just bottoms out. And then the left apical aneurysms, which I think we're all starting to learn more about. I think because imaging has gotten better, we're seeing them more often. So we have now 7 risk factors. We've lost 1. We've added other ones in with higher value. But what about modifiers like obstruction and AFib? Do they count?
Well, I think that certain situations, there can be some weight, again, given to other variables in the patient's profile that could help resolve an otherwise still ambiguous decision-making process about risk in the ICD.
Right.
I think that one of those has traditionally been, as you said, really high gradients at rest. We just to be clear, it's not a major risk marker itself. We don't put in devices based on high gradients. But if a patient already has 1 or more other risk markers that we've talked about, and maybe the patient themselves isn't sure about whether that's enough to move forward with a device, or physician isn't sure, looking at a arbitrator or modifier, as you said, could be helpful in helping resolve that decision. And for example, high gradients would be one of those arbitrators. I'm not sure AFib. Yeah, I'm not sure atrial fibrillation, in my view, would be an arbitrator. I think there's not enough evidence linking AFib to sudden death risk for it to really even rise up to be an arbitrator in that situation.
So what happened to multiple gene mutations? So if you have 2 or 3 mutations that have been identified, is that something that has any value in risk assessment?
Yeah, I mean, I think we appreciate, at least right now, the fact that a patient who has 2, and it's uncommon, but it can happen, 2 pathogenic sarcomere mutations is likely at greater risk for general adverse events related to the disease. But whether that itself is whether we have enough information to say that meaning 2 mutations is enough to put an ICD in a patient at this point who has no other evidence, for example, of increased risk because they don't have any other markers, is probably not where we're at the moment.
Okay. So now I'm going to pivot a little bit on something that was in table 1 here, which I think is an important piece of information for the community because I get this question a lot. Why would I get an ICD if I don't have any symptoms? So the correlation between being symptom-free from your HCM and being at high risk for sudden cardiac arrest, it's a really hard thing for people to put together. Yes, I have this disease. I know it. I saw it on the echo, but I don't feel it. But I have risk markers. in this data, it's showing, a pretty equal distribution between New York Heart Association class. And for those who don't know what that means, that's how you judge how many symptoms you have and how symptomatic you are from your disease. So a New York Heart Association class 1 is you really don't have any. 2 is some, 3 is more, 4 is about the worst you can be. So it looks like half of these patients are New York Heart Association 1 or 2.
Right. Yeah, great. It's a great point. And I agree. It comes up a lot, as well when I'm talking with patients for questions. So this is the deal, that the symptoms are not a marker of arrhythmic risk, okay? The mechanism that causes a patient with HCM to have symptoms, shortness of breath, chest pain, fatigue, are not mechanisms that we view as increasing risk for the electrical problem of sudden death, okay? Obviously, both are due to HCM, but the mechanisms and the pathways and what really is the relevant issues for symptoms do not drive what's relevant for arrhythmic risk. That is why when you went through that list just a minute ago about the major markers that help us identify patients at increased risk for sudden death and maybe candidates for that reason for ICD, symptoms isn't on there. It's not part of it because it isn't really a powerful predictor of the electrical consequences of the disease.
Excellent point. So in table 1, and actually you have 2 table 1s here. I'm a little confused. Maybe it's a continuation.
Yeah, it's a big table.
It's a big table. So you talked about genetics, and you did a breakdown of those you had genetic information on. And there are patients in this population that have myosin binding protein C, myosin heavy chain, troponin T, myosin light chain 2 and 3, TNNI, and then combination of mutations. Didn't seem to matter which gene it was, did it?
It did not. It did not. And I think that's a similar observation that's been made in other large studies in HCM patients that have been genetically tested and that have outcome, showing that there really isn't one particular gene or one or multiple different types of mutations, for example, that predict, at least reliably, the arrhythmic consequences of sudden death with this disease. It's probably because there are other factors involved that we don't really have a great handle on right now, like modifier genes and environment, 2 factors we know very little about, but probably are really relevant. And then 2 is that the number of mutations, just is so large that, and there's so many different ones, what we call private ones, that it's been very difficult to make any kind of real observation between mutation and outcome for that reason.
So out of all the patients that were in this study, what were the outcomes? What actually happened to these people with ICD? So 15% we talked about earlier had their device go off, but out of the 2,000 patients that you've been following, how many of those had a cardiac arrest that didn't get an ICD?
Well, so I don't have it in front of me, but I believe my numbers were 82 had ICDs that ultimately went off and delivered therapy for life-threatening rhythm. Okay, so those are 82 patients that we considered to be saves. They may have had a fatal consequence if the device had not been put in.
Right.
Then we had 5 patients who died suddenly without a device, but in whom 3 had been recommended to have a device, but they declined. Patient declined. And so that's important because if you just look at this data, the study statistically, intention to treat means that if you just look at what would have happened if you had used the markers that we talked about, and all the patients had agreed who had the recommendation that they were high risk, I believe, would have identified then almost 95% of the patients with this disease who went on to have a potentially life-threatening arrhythmia that were saved or would have been saved with the device. So that's really one of the major messages, is that, with this risk stratification strategy, this enhanced method, and in almost any cardiologist should be able to do this. It's not, I don't think what we have offered here is magical or so produced anywhere in the United States, or for that matter in the world, to provide patients, all patients, the most sensitive, and that's what we're talking about here, the most sensitive way of identifying who needs a device, ICD, and who doesn't.
So a follow-up question to knowing who needs it or not gets a little bit more complicated. So somebody gets diagnosed with HCM, they come to see you or some other HCM center of excellence, and they don't have any of these variables. Should they go home forever and feel like they're okay? Or how often should they revisit this risk assessment?
Well, yeah, we would say, no, we would never just send a patient out to the sunset and not to come back. That's absolutely not the right thing to do. We would say that in a stable patient who's been risk stratified, that they should be revisited, reevaluated again on a yearly basis, okay, at the minimum, particularly for young and middle-aged patients. Perhaps it could be spaced out a little bit more in older patients who have been stable their whole life, but for most of the population, it's a yearly visit.
I bring this up for a very specific reason, and that is sometimes we get a little bit complacent with our own disease process. And we think because we don't feel anything different, nothing could have changed in our risk stratifiers. And I just think it's really important for people to follow back up. Recently, one of our post-myectomy patients who had been following up periodically but was feeling better had a sudden cardiac arrest while riding a bicycle. And he's saved and he's fine, and now he's got an ICD. But we wonder, even after a major intervention like a myectomy or an alcohol ablation, what should be the follow-up? And I think it's really important to keep that annual visit, even if you feel like you might be doing okay.
Completely agree. And to that point, a patient's not going to know whether or not, even if they feel fine, whether they could be having more arrhythmias that they wouldn't be feeling, but could be detected by a monitor. And they don't know either whether or not they have had a change, for example, in the amount of scarring in their heart muscle. So there are a number of factors that we would look at that a patient would have no idea whether they've changed or not based on symptoms.
Couldn't agree more.
Yep.
So is there a way for us to score this or come up with a calculator or similar to the ESC, or are we just looking at clinical data points and assessing them as such?
Yeah.
That's a tricky question, I know.
Well, not really. I mean, the way I would answer that is that, I think that based on, this kind of information that we've been talking about today and this particular disease, I think that applying to this disease a score, a kind of a quantitative score that would be somewhat rigid because it would compute a number that would be attached to some kind of recommendation, is perhaps not the best strategy really for a disease where physician judgment, the ability to really look thoughtfully at the individual profile of every patient, because there is an enormous what we call heterogeneity to each patient, and that can't be accounted for in a risk score. That does make a difference in how you would judge a patient's risk and ultimately perhaps how you would recommend device or not. And so, simply put, I just feel strongly that this is not a disease and there may be other diseases where this isn't the case, but for our disease, HCM, a risk score perhaps isn't really the most reliable way to assess a patient's future risk for sudden death in the ICD.
Okay. I'm going to go off to a couple of other scenarios here, cases, if you will, and just get your input on a few. Before I do that, I'm going to ask if there's any closing points you'd like to make on the article itself. I know you had a great team working with you on it, and we appreciate all of their contributions. But before we go off to cases or scenarios, I'm going to call them, I'm going to tell you that I've generalized it to a certain degree. None of the information that we're giving on this video should be used for individual medical advice. You should be meeting with your individual physician to go over these factors. We're going to talk about some things in concept, not in how they affect a specific individual or case. So any parting thoughts on the article before we go off to Q&A?
Just again, that, I think that it underscores the very important principle in this disease that we need to continue in an era of big data, machine learning, quantitative scores, to value the ability to use, in this case, individual markers, physician judgment in the context of shared decision making with patients so they become fully informed and able to make the best decision for them, can ultimately result in a huge evolution in the decrease in sudden death events in this disease.
I couldn't agree more. I think we've come such a long way, a long way in 25 years.
We have.
And it's really amazing how far we've come. If you really stop and think of how complicated this can be to figure out, and all of the people that have been involved in figuring this out, specifically your dad, Maron, and the entire team there at Tufts and around the country who have helped provide pieces of the puzzle to put together for us all as patients. So we thank you. And I want to also give a nod to everybody who agrees to allow their information to be used for research, because we learn from them. So when you have that opportunity to check the little box to participate in research, please do it, because we all learn from everybody else's data, and it really is going to take a village to solve these problems. Okay, so scenario, 40-year-old who is recently diagnosed. Septal measurement, 1.6, 1.9, that range. No real scarring, 1 or 2% on MRI. But the family history is unclear because the family members who appear maybe have been affected because of a heart murmur noted in a medical file, or because maybe they had a symptom once or twice, they die from other reasons other than cardiac arrest, accidents or car accidents, that type of thing. One little episode of an NSVT, or maybe 3 episodes of NSVT. So there's 2 factors in a story like that makes you stop and say, we need more information in these 2 areas. What would you say about somebody who has family members who have died, but we don't quite know why they died, but they were young? Would you think maybe there's a cardiac component? Would you want to dig into those accidents a little bit more?
So, sorry, so the history is that there's been other family members who have died young, but from accidents, other causes, but we don't know whether they would have died from HCM suddenly or...
Well, so I'll give you the one example that is not this example, but I have a young man who was diagnosed. His brother died in a single vehicle car accident. And it turns out that when we started to look into the cause of death and the reason he left the road was probably because he had a cardiac incident, which caused him to go off the road. So just a car accident, you have to ask more questions. Is it, was it a single vehicle accident? Did somebody hit them? What are the factors around that?
Well, I hear you. And as you can imagine, as you well know too, there's a million different possible scenarios that can come up here when you're talking about the kind of clinical variables in history that are important in HCM decision making. I think for the scenario you brought up, I think all you can do is to do the best you can do to try to determine whether or not there may have been a rhythmic cause that drove that loss of consciousness that led to the accident, and that may be very difficult to do or impossible to do. There is judgment that comes into play there. I think that ultimately these are often unresolvable scenarios, and sometimes we have to assume that it could have been an arrhythmic sudden death. And if we assume that, how would that impact the recommendation of that patient you're seeing's risk? And then that involves, because there are assumptions, clearly a shared decision-making discussion there. And I say shared decision-making, meaning, just so everybody understands what we mean by that, that's really providing the patients, the physician's responsibility to provide the patients all that we know about the available information for that individual patient in that situation, so that that patient can, along with the physician and family members, make a decision for them that's the best possible using all the available information. Because there are many gray areas that come up, even when the information is complete, there are gray areas in this disease.
Mm-hmm.
The only way to resolve gray is to basically make a patient as fully informed as possible so that they can make an educated and empowered decision, essentially. And that's what this scenario that you're talking about, to me, speaks of.
I agree. And the question that is also involved with this case, we addressed earlier, NSVT. It's not just the fact that there was an NSVT. It's not just the fact that it happened 3 times, but the rate and how often it's happening are really critical facts.
Correct.
So let's pivot a bit to somebody who has already survived a cardiac arrest. A young athlete survives a cardiac arrest playing sport A and gets a defibrillator, and now is getting advice that it might be okay for them to participate in sport B, which is, by all accounts, still a very highly competitive. So let's say they had their event while playing basketball, now they want to play football. Is that something that the HCM experts of the world would say, great idea, or hold your horses, let's think about this?
Well, like almost all these areas, you probably could get different opinions about how to look at a situation, even among experts. But I think the consensus in general in this situation among the HCM experts would be that a patient that's had a prior cardiac arrest is at an increased risk, a real increased risk, to experience another arrhythmic event during sports that in this case would cause the device to go off. And the consequences of that are unpredictable. There could be injury. There could be the inability of the device to shock them out of multiple arrhythmias if they continued. Could be injury to other athletes. And so for those reasons, in a particularly high-risk patient like this, who's already had a cardiac arrest, I would personally strongly recommend against engaging in high-level sports, even with a device.
Kind of thought you might say that. A couple of questions that are popping up have to do with MRI safety after a device. So Phil has a question here. With MRI safe devices, are cardiac MRIs useful for other reasons?
Well, yeah. So Phil, I mean, if you've got a device already in, there are not a lot of reasons that you would need another cardiac MRI, because the main purpose, of course, of the MRI in most patients with HCM is to help inform about the need for an ICD. That said, I can think of a few uncommon scenarios where it may be helpful to answer a question with the cardiac MRI that echo may not be able to. And so to answer your question ultimately is, yeah, it can be safe if the ICD itself is MRI compatible and it's being done at a center with a lot of expertise and the infrastructure to do it safely and effectively.
Okay, we have another question. Molly, I am going to say this is not medical advice, so you're going to have to speak with your own doctor about this, but we'll get an opinion on one factor of this. So if somebody has no arrhythmias, no Holter monitors are clear, stress test is clear, a little bit of left atrial dilation, no quote hypertrophy, but we don't know who did the echo and whether there was an MRI or not, but they're showing some grade 1 diastolic dysfunction. Could you first define what grade 1 diastolic dysfunction is and address whether that is a risk factor that would require a device or not?
So grade 1 diastolic dysfunction, what that means is that there has been a grading system developed to characterize the degree of what we call diastolic dysfunction in hearts, not just HCM hearts, but this applies to all hearts. And it's an echocardiographic assessment. So it's with echo. And essentially it's looking at a number of different variables done on the echo to then be analyzed to determine the severity or the grade of what we call diastolic dysfunction, which refers to the ability of the heart to relax properly and efficiently diastolic dysfunction. That's what's called diastolic dysfunction. Grade 1 is the most benign of all of the grades. It goes from 1 to 4. In the general population, it can be used to help determine whether or not symptoms could be due to diastolic dysfunction. In HCM specifically, the grade of diastolic dysfunction is not a marker of increased risk for sudden death, which is why we don't consider it a risk factor. And so its use in HCM is limited for that reason.
Okay, so you're getting a little props here. Does hypertrophied heart continue to get more scarred and fibrotic over time? What causes that? And you got a little love note there from Bet.
Well, so the answer is that we don't really know yet how scarring, at least assessed by MRI, changes over time in patients with HCM. We're starting to collect that information. You can imagine it takes a lot of studies done by MRI serially in the same patient over time to kind of answer that. And so at the moment, it really isn't clear how scar changes in this disease and whether it accelerates in some patients at different ages versus others, not clear. So for that reason, what I recommend is that in young, middle-aged HCM patients that the MRI be considered repeating every 3 to 5 years for that reason. I think sooner is probably too soon.
So we have a nice dovetail into Erin's question. At what age do you recommend an MRI and stress test for children? And are these the same guidelines that apply to children regarding getting an ICD? So when do we start screening kids aggressively, and when do we think that these risk factors work for children?
Well, I think certainly if there's a question about diagnosis of a child, and that diagnosis is still somewhat ambiguous or uncertain with the echo, there's no question that that child, every effort should be made to try to get the MRI in that patient or child to help clarify whether the wall thickness is increased enough that a diagnosis is made or not.
Okay. And the guidelines still hold for children?
I think for scarring, there is less information about scarring and risk of sudden death in the pediatric HCM population. There's some, but not as much as adults. I think what's reasonable is, again, if there's a lot of scarring seen in a child, that has to be factored in a way that probably results in, again, a shared decision-making discussion and used with other markers to help determine whether that's enough for an ICD.
Yeah, that gets a bit complicated. We've had a couple of questions here, and I'm not going to put them up individually, but oh boy, that's a really long one. But I want to deal with this. So while we're talking about enhanced risk assessment, there's been a number of questions about general screening and a couple of stories about young people who have died with what was believed to be an asymptomatic HCM and found on autopsy. This gets into a whole other conversation that we could get into on another day about community-based screenings versus cardiology screenings or mandated screenings of some sort. But the overall approach to these risk stratifiers are the trick that we already have to identify the patient, and then we can do this work.
Yep.
I think the part of this article that resonates with me and these people who have unfortunately lost loved ones is that the asymptomatic patient is at risk. How do we balance the very complicated question of there are going to be people at risk who do not necessarily get to cardiology? How do we enhance that? This is a really tough question. I apologize for throwing it at you because it's almost an unanswerable at this point. But what do you think might work? Do you have any ideas?
I don't know the answer. I'll be honest. I mean, I have to be straight up, in certain situations with certain questions. And I think that's a great question. It is clearly that's a problem. I don't know if I can provide a solution to that problem at the moment, meaning being able to identify asymptomatic patients in the general population who are not related to somebody with HCM, who could still be at risk for an adverse complication. How do we find them better than we are? I don't know the answer to that.
I honestly think the question doesn't lie in medicine. I think it lies in legislative action and changing the protocols for well child exams to help identify families who are at risk and asking different questions in those well child exams that the parents actually fill out. So maybe we'll be able to get somewhere with that legislation to identify more people. But mandating, a test for a population with a very low yield, I don't think it's going to happen anytime soon. But
Yep.
We're still all evolving. We're all learning together. So to those of you who lost a loved one to undiagnosed HCM, we are looking for methods to help identify the undiagnosed, but it is going to be a major challenge. And I look forward to having those conversations with you.
Maybe it's important to mention, just on that note, just to be clear, that the genetic markers in HCM are only present in 30% of the patients.
Yeah.
So for that's one of the reasons then why there would be no justification at the moment to putting all the genetic markers on the newborn screening panel, which contains a lot of other diseases, including other genetic diseases. The yield, as you just said, is just simply too low at the moment.
Exactly.
For that to make sense. Yeah.
Having a little bit of a technical difficulty here here we go. Lori has a very big question that's taking up the whole screen. So I'm just going to flash it real quick and then I'm going to read it from below. Newly diagnosed, was competing in short distance runs and triathlons. I think did strength training as well. While waiting for an MRI, told to keep active, but no competitive sports, no pushing it. Is there a safe heart rate to target? I'm struggling to figure out where the activity levels are. Last night, went for a run. Her heart rate hit 160, brought it down to 140. But this is coming from a family, she's 48, and a sister who had sudden death at 18, that now they're thinking is due to HCM, but they didn't know that before. And the answer to that is yes, in Toronto, in Canada. So if somebody is what I call China doll mode, which is you're diagnosed, but we don't know your risk yet, so sit on the shelf and look pretty for a little while we figure this out, should they be running with getting our heart rates up into the 160s, or should they just give it a little time so the clinicians can work this out?
Yeah, I mean, if they've been diagnosed, then the answer to that question is that they should follow the recommendations for physical activity restrictions in HCM, which I'll say, as a segue to that we don't really view it about heart rate. I mean, it's hard to put heart rate limits. It's more about intensity. That's really the key. So, for example, as I always tell patients when they ask, it's the peak exercise. In our view, you should really still be able to have a full conversation if somebody was theoretically next to you without straining to complete words or sentences. At that level, you can go as long as you want, nice and steady and even, not not engaging in burst exertion, as part of that or any other activity. So things where you're going, 0 to 60, interval training, burst exertion, stadium steps. That is the kind of thing we really want you to stay away from. Mild to moderate recreational aerobic activity, where at peak exercise, again, you're able to complete full sentences, is permissible and viewed as safe in patients with HCM. We don't want patients to stay in the corner and trade one disease for another. That's a mistake, and not warranted, based on the observational data of the last several decades. So that's in general where what I would say about where the limits lie for physical activities.
Okay, you've been more than gracious with your time, and I know you told me you had a 3 o'clock meeting, but you're going to be typical Marty Maron, and you're going to be 5 minutes late.
Typical is 10, but let's do 5.
Okay, so we're going to wrap up. You have the thanks of the community here. There's a whole bunch of people that have jumped in to say hi, very grateful patients and people who made a big difference in their life, myself included. So thanks for your time, and we hope to be able to do this again. And for those who are watching, we are hoping to create a series of these conversations when a new article comes out, to have conversations with the authors and share this information with the patients in real time, where you can ask questions and understand this very complex scientific literature in a very easygoing way. So Marty, thank you so much for your time today. Give my best to the rest of the team up there in Boston, and we'll talk soon.
Thanks, Lisa. You keep up the good work too. Thank you.
Thanks. Bye-bye.
Thanks.